Hello, my name is Amy Lucero, and I am a student of MSW 6104 with National University. And I will be presenting my PowerPoint titled "Examine a Case Study Using Specific Interventions and Treatment Plans." Case presentation, and the client is Anne, 49 years old, and she is a female. This presentation reviews the case of Anne, a 49-year-old woman presenting repeatedly to the emergency department with fire-setting aggression and alcohol intoxication. This presentation will focus on social determinants of health, social justice considerations, and differential diagnosis. I will analyze symptoms, identify primary diagnosis, and rule out diagnosis, and further discuss evidence based social work interventions. The diagnostic reasoning is guided by the Diagnostic and Statistical Manual of Mental Health Disorders, 5th edition. I will also consider how structural inequities affect assessment, engagement, and treatment planning. The case highlights the importance of trauma informed and culturally responsive practice when clients minimize symptoms or present with conflicting collateral information. The background. Anne presents with a pattern of escalating behavioral incidents involving alcohol use, aggression, and fire setting. She minimizes risks and contradicts collateral information. She has multiple ER visits over 2 months that show increasing instability. She denies suicidal ideation, hallucinations, or ongoing alcohol use despite high ethanol levels. Her husband reports escalating drinking and impulsive behaviors. So these discrepancies raise concerns about insight and reliability of self report. Repeated emergency encounters suggest chronic untreated psychiatric illness and possible substance misuse. This pattern is clinically significant because recurrent crises often indicate mood instability and impaired judgment. The presence of fire setting, alcohol intoxication, and aggression significantly elevates safety risks to self and others. The timeline of her ER visits. The timeline reveals a cluster of crises in a short period of time. Episodes include alcohol intoxication, aggression, passive suicidal statements, and fire setting. The repeated fire incidents are especially concerning because they represent impulsivity and impaired risk. The ethanol levels indicate heavy drinking despite her denial of ongoing alcohol use. This suggests minimization or poor insight, which commonly occurs in mood disorders and substance use disorder. The clustering of events across weeks is consistent with an untreated manic or mixed episode, particularly when combined with sleep disruption, irritability, and impulsivity. The pattern also signals escalating family conflict and safety concerning requiring intervention. Relevant symptoms. Key diagnostic symptoms include impulsive fire setting, irritability, aggression, and poor insight. Fire setting represents severe impulsivity and impaired judgment. Alcohol intoxication may worsen mood instability and disinhibition. Anne's guarded presentation and minimization of risks are clinically meaningful as individuals experiencing mania often lack insight into severity of their behavior. Collateral information contradicts her self report, suggesting impaired reality testing or defensiveness. The recurrent crisis indicates persistent mood dysregulation lasting weeks. These symptoms align with manic or hypomanic features with co-occurring substance misuse. The combination significantly elevates safety risks and supports the need for diagnostic clarification. Social determinants of health. Social determinants strongly influence symptom severity and treatment access. Barriers to culturally responsive mental health care often delay diagnosis and treatment in Black communities. Structural inequities and stigma may contribute to underreporting of symptoms and reluctance to engage in treatment. Repeated police involvement suggests crisis driven care rather than preventative services. Gender and family caregiving stress may worsen mood instability. Alcohol may function as a maladaptive coping strategy for stress and relationship conflict. Social determinants can prolong untreated bipolar disorder and increase emergency service utilization. So, addressing social determinants of health is essential to reducing long term risk and improving treatment adherence. Social justice and mental health. Research shows Black patients are more likely to be misdiagnosed with psychotic disorders and less likely to receive mood disorder treatment. Structural racism influences access, trust, and treatment outcomes. Crisis responses often involve law enforcement rather than mental health professionals, including increasing trauma and stigma. Social workers must actively counter systemic biases through culturally responsive assessment and advocacy. Addressing social justice issues, reducing disparities, and improving outcomes. These factors are emphasized by the Substance Abuse and Mental Health Services Administration, which highlights equity and recovery oriented care as core principles. Addressing social justice in practice. Social workers play a critical role in reducing disparities. Disparity. Cultural humility requires recognizing implicit bias and validating lived experiences. Advocacy includes connecting clients to accessible and culturally competent services. Trauma informed care reduces re traumatization and repeated crisis interventions. Engaging family supports improves treatment adherence and reduces relapse risk. And social workers also help clients navigate healthcare systems and access resources such as substance use treatment and psychiatric care. These practices promote equity and improve long term outcomes. Differential diagnosis. Step 1, the symptom analysis. The duration of clustering of symptoms suggests an ongoing mood episode rather than isolated incidents. Bipolar manic episodes require at least 1 week of elevated or irritable mood and increased activity or impulsivity. Anne's behavior spans several weeks with escalating severity. Fire setting and aggression demonstrate impaired judgment and risky behavior. Alcohol use complicates the presentation but does not fully explain the persistent mood and behavioral changes. This symptom pattern meets criteria for a mood disorder, requiring further diagnostic clarification. Differential diagnosis. Step 2, possible diagnosis. Multiple diagnoses must be considered. Bipolar 1 disorder is strongly suggested by impulsivity, irritability, and repeated crises. Alcohol use disorder is supported by high ethanol levels and hidden alcohol. Substance induced bipolar disorder must be considered because alcohol can mimic mania. Borderline personality disorder is a rule out due to emotional instability. and interpersonal conflict. Pyromania is unlikely but considered due to repeated fire setting. However, fire setting appears impulsive rather than pleasure driven. Differential diagnosis requires elevating mood symptoms independent of substance use. Primary diagnosis. Bipolar 1 disorder is the most consistent diagnosis and demonstrates impulsivity, irritability, risk taking behavior, and poor insight. These symptoms persist beyond acute intoxication episodes. Alcohol use disorder is a secondary diagnosis due to repeated intoxication and denial. Substance induced bipolar disorder remains a rule out because alcohol may exacerbate symptoms. Diagnostic clarification requires longitudinal assessment and sobriety monitoring. According to the National Institute of Mental Health, bipolar disorder often co-occurs with substance use disorders, complicating the diagnosis and treatment. Interventions. Integrated dual diagnosis treatment. Integrated treatment is essential because co-occurring disorders worsen outcomes when treated separately. So psychiatric medication stabilizes mood, while substance use treatment reduces the relapse of triggers. Psychoeducation improves insight and treatment adherence, and motivational interviewing can address denial of alcohol use. Family involvement supports monitoring and safety, and integrated care reduces hospitalizations and improves long-term recovery. Intervention number 2 includes includes safety and crisis planning. Given Anne's fire setting behavior, immediate safety planning is critical. Interventions include removing ignition resources, developing crisis plans, and involving family supports. Social workers will collaborate with family to identify warning signs and emergency contacts. Safety planning reduces risk of harm and supports stabilization. This intervention directly addresses the most dangerous behavior. And what is the role of the social worker moving forward? Long-term recovery requires ongoing support. Social workers coordinate psychiatric care, substance treatment, and community resources. Advocacy reduces stigma and improves access to culturally responsive services. Continued therapy helps improve insight and coping skills. Ongoing monitoring reduces relapse and emergency visits. These are my references. Thank you.